Welcome to the Radont Smart Review GI Cancer series. We're here to really get into the critical topics in radiation oncology. Make sure you're fluent, confident, ready for anything.
Whether that's your boards or a complex case walking into clinic.
Exactly. So today we're diving into something that's really been transformative in GI rad onc.
Yes, stereotactic body radiation therapy, SBRT, for hepatocellular carcinoma, HCC.
And we're not just scratching the surface here. This is like a masterclass.
Right, we're focusing on the definitive case for SBRT, those crucial dosimetric details, and the non-negotiable constraints, the things you absolutely need for safe, effective treatment.
It feels like for the longest time, radiation oncology was kind of on the sidelines for HCC, right?
Oh, definitely. Often just palliative care.
Yeah, and largely because of those concerns, understandable concerns about radiation-induced liver disease, but things have changed.
They really have. Modern SBRT has truly stepped into the spotlight. It's moved way beyond that previous fringe role.
We've seen incredible advancements. It lets us treat this really challenging disease with precision and, maybe more importantly, with confidence.
It's a field that's completely rewritten its own rules for HCC. We're talking curative intent local therapy now.
Something that was honestly unimaginable for a lot of these patients not that long ago.
Absolutely. And in our previous discussions, we sort of laid out the foundational HCC toolkit.
Right, we covered staging, the IR techniques like TACE and RFA.
Transarterial chemoembolization, that's TACE, and radiofrequency ablation, RFA, and, of course, the evolving systemic therapies.
All vital pieces. It's always a multidisciplinary approach for HCC, isn't it?
It has to be. It's just such a complex disease. One modality, well, it rarely gives you all the answers.
And while those traditional treatments, TACE, RFA, they certainly have their place, they offer valuable options.
But they do come with limitations, significant ones sometimes.
Especially when you're really focused on achieving durable local disease control. That's the key phrase, right? Durable control.
Exactly. Think about larger tumors, or ones in tricky spots anatomically.
Like right next to a major vessel, or deep inside the liver.
Yeah. Getting a robust, long-lasting response with TACE or RFA in those situations can be incredibly difficult.
And this is precisely where SBRT doesn't just change the game.
It completely redefines it. We're delivering ablative tumor-killing doses.
With surgical precision, targeting the tumor accurately, but also minimizing that collateral damage to the healthy liver around it.
It's a fundamental shift in how we approach local control for HCC. It gives us a solution when other methods just hit their limits.
You've really hit the core point there. For many HCC patients, the evidence now is, well, it's pretty clear.
SBRT isn't just an option. It's proving to be the superior choice for local control.
Superior choice, okay? That's a strong statement.
It is, but the local control rates often surpass those traditional approaches. And importantly, with a remarkably favorable toxicity profile, if it's applied correctly.
So this isn't just theoretical talk. It translates directly to better outcomes for patients.
It really does.
Okay, so superior choice. Let's dig into that. What's the hard data? Where did SBRT really start to, prove itself against established therapies like RFA?
Great question. And the data is compelling. So when we first started comparing SBRT versus radiofrequency ablation RFA, a pivotal study that really caught people's attention was from Wall and colleagues. It was published in JCO.
Okay, Wall et al. And what kind of study was it? Randomized?
No, important point. It wasn't randomized. It was a rigorous retrospective comparison, though. Pulled data from multiple centers.
Aiming to directly compare SBRT versus RFA for HCC tumor?
Exactly. Head-to-head based on the data they had.
And what did it show? Was there a meaningful difference, especially for maybe the tougher tumors?
There absolutely was. The findings were quite striking, particularly when you sliced it by tumor size.
Ah, size matters here.
Definitely. The study showed significantly better one-year freedom from local progression, FFLP, with SBRT, but specifically for HCC tumors larger than 2 centimeters.
Okay, so over 2 centimeters, what were the numbers?
Impressive numbers. 97% freedom from local progression with SBRT versus 84% with RFA for those larger lesions.
Wow, that's a 13% absolute difference. That's clinically huge.
It really is. It means fewer local recurrences for your patients. Less need for, potentially costly and burdensome salvage therapies down the line.
So for a tumor that's maybe a bit bigger or in the tricky spot?
This isn't just a number. It means potentially better quality of life, a much higher chance of long-term local control. lets you focus on managing the rest of their disease.
I like the analogy for residents thinking of SBRT like a laser-guided missile.
Yeah, that's a good one. Highly precise, targets only the tumor, powerful ablative dose right where you need it.
Whereas a RFA, while it works well for small stuff.
Right. For small peripheral lesions, it can be great, but for larger tumors or ones near big blood vessels, it's more like trying to hit a moving target with a less focused energy source.
And that's where the famous heat sink effect comes in, right?
Precisely. That blood flow through nearby vessels just whisks the heat away.
Making it really hard to get a complete durable ablation, especially at the edges.
It's a critical distinction. For lesions under 2 centimeters, RFA can be quite effective. The Wall study actually showed no significant difference there.
Okay, so small ones, RFA is still a very good option.
Yes, but as soon as you get larger or more vascular, SBRT's ability to deliver that precise high-dose punch, regardless of blood flow, well, it really puts it into a different league.
It's about confidently ablating the whole tumor volume, minimizing the risk of, like, a geographic miss or leaving viable cells behind.
Exactly. You get better coverage, more certainty.
That makes perfect sense. Okay, so if SBRT beats RFA for larger tumors, how does it compare against TACE? That's been a workhorse for HCC for a long time, right?
It has, especially for multifocal disease or larger tumors, maybe not suitable for ablation. But the comparison with SBRT, well, it's even more compelling, believe it or not.
Really? How so?
Well, TACE is great for palliation, sometimes bridging to transplant, but it often struggles with achieving that durable, complete local control.
Because of how it works, right? The embolization and chemo effects can be kind of patchy.
Exactly, heterogeneous distribution within the tumor. It's not truly ablative in the same way SBRT is.
And the data shows this difference clearly.
Oh, absolutely. One of the earlier, quite impactful studies was that Michigan retrospective by Sapir and colleagues.
Okay, Sapir, what did they find comparing SBRT and TACE?
The results were pretty stark. The 2-year local control rate was a remarkable 91% with SBRT.
91% at 2 years and TACE?
A mere 23%.
Wow, 23 versus 91. That's not even close.
It's a chasm, like you said. TACE aims to cut off blood supply, deliver chemo. SBRT aims to obliterate the tumor cells directly with radiation. Different mechanisms, different outcomes for local control.
And just in case anyone thinks that Michigan's study was maybe an outlier.
Right. There's the TRENDY phase 2 trial. That further confirmed the difference.
Trendy. Okay. What did that show?
It was prospective, though single arm for SBRT, but it looked at both. It showed an astounding 100% 2-year local control with SBRT.
100%?
Yep, versus 44% with TACE.
Okay, so for local disease control, especially durable local control.
It's really not even a close contest. SBRT consistently comes out ahead in achieving that critical goal.
Which often means fewer repeat procedures, maybe better quality of life for the patient.
Absolutely. These comparisons really highlight why SBRT has shifted from maybe a niche or salvage treatment to a frontline option in many HCC algorithms. The data is just too strong to ignore when local control is your main goal.
Okay, this is where it gets, for me, really interesting, where SBRT has opened doors for patients who had very few options before.
You're talking about portal vein tumor thrombosis, PVT.
Exactly, PVT. For residents listening, this isn't just a minor complication. It signals aggressive disease, usually a poorer prognosis.
And historically, it was often a major contraindication for curative treatments, like resection, transplant.
Even TACE, right, because of the risk of liver ischemia.
Precisely. So what were these patients left with before SBRT really came onto the scene?
Not much, often just palliative systemic therapy like sorafenib back then, which, let's be honest, offered pretty modest survival benefits.
So SBRT has fundamentally changed the outlook for these patients. And the landmark trial here, the one that truly cemented SBRT's role in this high-risk group.
That would be RTOG 1112.
Exactly. Radiation Therapy Oncology Group 1112. A phase 3 randomized trial, our highest level of evidence.
And it randomized patients with advanced HCC to sorafenib alone.
Versus SBRT, followed by sorafenib.
And what's really crucial to remember about the patients in this trial, given we're talking about PVT.
It's critical. It shows the severity of the disease they were treating. A remarkable 74% of patients in RTOG 1112 had macrovascular invasion.
74%. So large vessel invasion, often PVT.
Exactly. This highlights the truly high-risk, advanced nature of who they enrolled. This wasn't a trial for tiny early HCCS. It was for the tough cases.
Now, I seem to recall RTOG 1112 closed early, right? Does that weaken the findings at all?
That's a really sharp question. And yes, it's important for residents to understand. The trial was closed early.
But why? Not safety concerns.
No, not safety or futility. It was actually closed because new systemic agents got approved rapidly in HCC, changing the standard of care while the trial was still running.
Ah, okay. So that means it was technically underpowered for its original primary endpoint, overall survival.
Correct, if you just look at the original sample size calculation. But, and this is key, the results were still incredibly compelling and really influential.
So what did they actually see for survival?
There was a strong trend toward improved overall survival. And critically, that trend actually hit statistical significance after they adjusted for important prognostic factors.
Like child-Pugh class, disease burden, things like that.
Exactly. When they accounted for those, the difference was significant. The median overall survival was 15.8 months with SBRT plus sorafenib,
Compared to?
12.3 months with sorafenib alone.
Okay, so over 3 months improvement in median overall survival. For this incredibly difficult patient group with PVT, that's a big deal.
It truly is. And not only that, SBRT also significantly improved progression-free survival and time to progression.
Which is also huge for patients, right? Delaying progression, maybe improving quality of life.
Absolutely. Delaying progression, potentially delaying the need for more toxic treatments later on. It matters a lot.
So wrapping this up for the resident listening, what's the takeaway when you see that HCC patient with PVT on the consult list?
The takeaway is that RTOG 1112 gives us our highest level evidence. Phase 3 randomized data showing SBRT is safe and effective for HCC, especially with PVT.
It really opens up a vital treatment path for patients who previously had very limited, often just palliative options.
It truly does. This trial solidified SBRT's role in advanced HCC. It needs to be in your toolkit, part of the discussion for these complex cases.
Imagine telling a patient who thought they had no local options, actually, we have this powerful tool.
Exactly. It's a game changer for those individuals.
Okay, so we've firmly established the why, the compelling evidence supporting SBRT. Now let's get into the how. How do we actually prescribe this safely and effectively? What's the main goal dose-wise?
Right. The overarching goal for HCC SBRT is delivering an ablative dose.
Ablative. What does that mean in practical terms?
It means a dose high enough to cause direct tumor cell death, microvascular damage, essentially aiming for a surgical equivalent kind of tumor kill.
And how do we quantify that? Is there a target?
Generally, yes. We define it using the biologically effective dose, or BED. We aim for a BED of 100 gray or more, BED 100 gray. And that helps compare different fraction schemes, right? Exactly. It accounts for the radiobiology, ensures we're delivering enough biological punch, even if the physical dose and number of fractions vary.
So what's a common prescription that gets you to that BED of 100?
A very common, very effective regimen is 45 to 50 gray, delivered over 5 fractions.
45 to 50 gray and 5. Okay.
Yeah, gray being the absorbed dose unit, fractions the number of treatments. This 5-fraction approach is frequently used, generally well tolerated, and balances efficacy with, practical treatment delivery.
But it can't be one size fits all, right? Especially with HCC patients often having underlying liver issues. How do you tailor that dose?
You've hit the absolute critical point. Tailoring is essential. You have to consider the patient's individual liver function, often using the Child-Pugh score.
Right, looking at bilirubin, albumin, INR, ascites, encephalopathy.
Exactly. And maybe even more importantly, you tailor based on the volume of normal, healthy liver tissue you can safely spare.
Because a Child-Pugh A liver can take more radiation than a Child-Pugh B liver.
Precisely. And this leads us straight to a critical tool. The RTOG 1112 protocol's dose de-escalation schema.
Ah, yes. The de-escalation schema. This is key for safety.
It's designed specifically to balance hitting the tumor hard enough while minimizing that risk of radiation-induced liver disease, RILD.
Okay, let's make this super memorable, especially for boards in clinic. I like using a mnemonic for the RTOG 1112 schema.
I'll use
555 for 50, 1345.
555 for 50, 1345. Okay, break that down.
5 fractions is the common regimen. 50 gray is the max dose you shoot for initially. 13 gray is the critical mean liver dose threshold for the normal liver. And 45 gray is your first de-escalation step if you can't meet that 13 gray threshold.
That's actually really good. 555 for 50, 1345. It nails the key numbers.
It's a quick way to recall the core parts when you're, maybe putting a plan together or reviewing one quickly.
Absolutely. And that mnemonic really captures the central challenge. How aggressive can you be with a tumor dose without tipping the liver over the edge?
So how does it work in practice? You start planning for 50 and 5.
Yes, you start by planning for that maximum dose, 50 grays in 5 fractions, assuming you can achieve it safely. Then you meticulously calculate the mean dose to the normal liver.
Which is the total liver volume minus the GTV, the gross tumor volume?
Exactly. Total liver minus the visible tumor. That's the healthy liver volume you need to protect.
And if you can keep the mean dose to that normal liver below 13 gray?
You're good to go. If you achieve a mean liver dose of 13 gray or less to that normal liver volume, you can confidently proceed with the full 50 gray prescription. That's your green light.
And these numbers, 13 gray, they aren't just pulled out of thin air, right?
Not at all. They come from years of clinical data, dose volume modeling, all aimed at keeping that RILD risk below an acceptable threshold, maybe around 5%, while still delivering that ablative punch. Understanding the why helps you troubleshoot when you can't hit a target.
Okay, but what if you can't hit that 13 gray mean dose for the uninvolved liver? Maybe the tumor is huge or centrally located.
That's your signal. That's when the systematic de-escalation kicks in.
So you drop the dose.
Step by step.
Yeah.
You go down from 50 to 45 gray. If you still can't meet the mean liver dose constraints, you go to 40, then 35, then 30.
All the way down to?
Down to a minimum floor of 27.5 gray in 5 fractions. Each step down is 5 gray, except that last little 2.5 gray step.
And does the acceptable mean liver dose change as you de-escalate?
Yes, it generally shifts slightly upwards. For instance, at that lowest dose level, 27.5 gray, the maximum allowable mean liver dose is 17 gray.
So it gives you a bit more leeway on the liver dose if you have to reduce the tumor dose significantly.
Exactly. It's a structured approach, a clear roadmap. It ensures that even if liver reserve is low, or the tumor makes sparing hard, you still have a method to deliver the highest possible safe dose.
This schema is absolutely critical then. Balancing efficacy and minimizing RILD is the name of the game.
It truly is. RILD can be devastating, so you have to respect these limits.
Okay, moving from prescription to safe delivery. Let's talk constraints, the absolute red lines.
Yes. Safe SBRT is fundamentally about respecting critical constraints. There are 2 you absolutely must know. For boards, yes, but more importantly for patient safety every single day. Non-negotiable.
What's number 1?
Number 1 is the uninvolved liver constraint. This is all about preventing RILD.
Which can lead to liver failure, severe fibrosis, really bad outcomes.
Exactly. So you must spare a sufficient volume of functional liver to maintain its critical functions. The widely accepted guideline, from K1 Tech consensus groups,
is that you need to ensure at least 700 cubic centimeters, cc's, the uninvolved liver receives a total dose of less than 15 gray.
Precisely. For a typical 3 to 5 fraction SBRT regimen, 700 cc's getting less than 15 grays. This is your absolute safety net, regardless of the prescription dose.
So the high-yield way to remember this, the phrase you'll hear constantly, V15 must be greater than or equal to 700 cc for the normal liver.
Correct. V15 less than or equal to, the volume receiving less than 15 gray must be at least 700 cc. So if you phrase it as V15G.
Right, the volume receiving 15 gray or more must be limited. Or, put another way, the volume receiving less than 15G.
Must be greater than or equal to 700 cc. Let's stick with that phrasing. V15G, 700 cc. That's probably the clearest.
Perfect. V less than 15 gray must be greater than or equal to 700 cc. If your plan violates this, huge red flag. Needs replanning.
Absolutely. This isn't just about passing an exam. It's about preventing a potentially fatal complication.
What actually happens if you miss this? What does RILD look like?
Missing this constraint dramatically increases the risk. RILD can manifest as fatigue, jaundice, ascites, elevated liver enzymes, and it can progress to outright liver failure. It's often progressive, debilitating, very hard to manage.
So when you're reviewing a plan, check this first. Always.
Always. Even if tumor coverage looks amazing, if this constraint isn't met, the plan is unsafe. Period.
Okay, constraint number 1, spare enough liver volume, V15 GRI, 700 cc. What's the second non-negotiable?
The second one, which needs real vigilance, is the central biliary tract. We often call it the no-fly zone,
The no-fly zone. Why?
because radiating this area to high SBRT doses carries a significant risk of biliary stricture.
And biliary stricture is bad news.
Very bad. It can lead to serious complications. Cholangitis, recurrent infections, eventually liver failure. Often requires invasive procedures like PTC drains or stents. Really impacts quality of life.
How do we define this no-fly zone anatomically?
Typically, it's defined as the portal vein, starting from where the splenic vein joins it, going up to the first split of the left and right portal veins, plus, crucially, a margin around it.
How big a margin?
Usually about a 1.5 centimeter margin. That's critical to account for breathing motion, set up uncertainty, beam penumbra.
And is there data backing up the danger here?
Yes, strong data. Osmondson and colleagues at Stanford showed a clear correlation between the dose delivered to this region and the risk of hepatobiliary toxicity. Exceeds certain dose volume limits, and the stricture risk jumps dramatically.
So is there a practical rule of thumb, a dose limit for this zone?
There is. For a 5-fraction regimen, a common guideline is to keep the volume of this no-fly zone that receives 40 gray to less than 21 cubic centimeters. V40G, 21 cc for the central biliary tract.
V40 less than 21 cc. Another key number to remember.
Absolutely. For boards and for practice.
Okay, but here's the clinical dilemma. What if your tumor is right next to this no-fly zone? Or worse, what if it's actually invading into it?
That is precisely one of the toughest calls you'll make in HCC SBRT. You're balancing trying to cure the cancer locally versus causing a devastating, potentially life-altering toxicity.
So what do you do?
If your target tumor abuts or invades this region, dose de-escalation of your SBRT prescription is mandatory. You simply cannot deliver a full ablative dose to the central biliary tract.
You have to compromise on the tumor dose to protect the bile ducts.
You do. And this often requires a very frank, very transparent discussion with the patient about that trade-off. You explain that a lower dose might mean a slightly higher risk of the tumor coming back locally.
But it's necessary to prevent a biliary stricture that could severely harm them.
Exactly. And sometimes you might even need to pivot to a different treatment entirely, maybe surgery if they're a candidate, or perhaps consider radioembolization, TARE, using therapies or Sortex.
Because TARE targets via the artery and might give a better dose distribution for central tumors?
Potentially, yes. Even if it doesn't quite achieve the same level of truly ablative local control as high-dose SBRT, it might be safer for those very central lesions. It becomes a critical discussion for your multidisciplinary tumor board. But the bottom line is you cannot compromise that central biliary constraint.
Okay, that's really clear. Now, we've mostly talked about photon SBRT. That's the workhorse, right? Widely available, proven effective. But we should touch on other modalities, particularly proton therapy. What makes protons attractive for HCC?
Protons are an excellent option, especially for very large tumors, or maybe tumors very close to other critical structures that are tough to spare with photons.
Like bowel, stomach, spinal cord.
Exactly. Or in reirradiation cases, the physics is the key difference. That Bragg peak.
Right, where the protons dump most of their energy at a specific depth and then stop, essentially.
Precisely. There's very little exit dose compared to photons. This allows for potentially superior sparing of the normal liver and other nearby organs.
Which could mean you can either push the tumor dose higher or maybe treat patients with more compromised livers more safely.
Both are potential advantages. The Hong study in JCO back in 2015 showed excellent local control, 95% at 2 years, with hypofractionated protons for HCC. So it's certainly effective.
And this naturally leads to a current hot topic, something residents are probably hearing about, the NRGGI-003 trial.
Yes, NRGGI-003. That's the ongoing phase 3 study directly comparing protons versus photons for HCC.
A head-to-head randomized comparison.
Exactly. It's aiming to definitively answer whether those dosimetric advantages of protons actually translate into better clinical outcomes, like improved overall survival or reduced toxicity in a large, multi-center trial.
The results will be really important for guiding treatment decisions in the future.
Hugely important. It might help us figure out which specific patients really benefit most from protons over photons in a randomized setting. Definitely a trial everyone should be watching.
And just circling back quickly to RTOG 1112 closing early, it really highlights how fast things move in HCC, doesn't it?
That's a perfect example. The whole landscape changed mid-trial with new systemic agents.
It's a testament to the dynamic nature of this field. New evidence, new treatments popping up constantly.
It really is. It shows you can't just memorize today's guidelines. You have to understand the principles and keep learning because things change fast.
Okay, let's broaden out slightly. Beyond photons versus protons, what are some other areas of maybe controversy or ongoing research in HCC SBRT that residents should be aware of?
Good question, because it's definitely not a solved field. One big area is SBRT as a bridge to liver transplant.
Right, keeping patients within transplant criteria while they wait, or maybe even downstaging them.
Exactly. SBRT is proving to be a powerful tool here. High local control rates can keep patients eligible or sometimes make them eligible if they were initially outside criteria.
But it's not straightforward, is it?
No. The optimal timing, patient selection, it's still debated. And it requires incredibly close collaboration with the transplant surgery team. You have to be on the same page.
What about using SBRT for recurrences, say after TACE or RFA, or even after prior SBRT?
Another area of active research, reirradiation of the liver is tricky, right? Cumulative toxicity is a major concern.
For sure.
But with highly precise SBRT, careful planning, re-SBRT can be considered in select patients.
Select patients meaning.
Maybe small, isolated recurrences, ideally away from previously treated high-dose areas and definitely away from that central biliary zone. You have to be very careful about the remaining liver function, too. It's not routine, but it's an option for the right patient, always after a thorough risk-benefit discussion.
And finally, what about combinations? RTOG 1112 combined SBRT with sorafenib. Now we have immunotherapy, newer TKIs. What's the thinking on combining SBRT with those drugs?
Now you're talking about probably one of the most exciting areas, the synergy between radiation and systemic therapy, especially immunotherapy.
We hear about that across many cancer types.
We do, and HCC is no exception. There's preclinical data suggesting SBRT might induce an abscopal effect, an immune response against distant tumors.
And potentially enhance how well immunotherapies work.
Exactly. So there are several ongoing trials looking at combining SBRT with newer TKIs or immune checkpoint inhibitors in different settings up front. Salvage?
The hope being better local and systemic control.
That's the hope. Better overall outcomes. This is an area where the standard of care is actively being written right now. And you, as residents, you'll be at the forefront implementing these new paradigms as they emerge.
It really underscores that need to stay current, doesn't it?
Absolutely. What you learn today might just be the starting point for a whole new approach tomorrow.
Okay, fantastic. Let's shift gears now and test your knowledge with our board blitz section.
All right, time to apply what we've covered.
Exactly. Consolidate these key concepts. I'll give you a classic board-style case. Take a second, pause if you need to, think it through, and then we'll break it down.
Ready when you are.
Case 1. In that retrospective comparison of SBRT versus radiofrequency ablation for hepatocellular cancer by Wall and colleagues, improved freedom from local progression was observed with what is it? ASBRT for tumors greater than 2 centimeters, BSBRT for tumors less than 2 centimeters, CRFA for tumors less than 2 centimeters, DRFA for tumors greater than 2 centimeters. What do you think?
Okay, thinking back to Wall, the key differentiator was size. For the smaller tumors under 2 centimeters, they were pretty similar.
Right.
But for tumors 2 centimeters or larger, SBRT showed significantly better freedom from local progression. That heat sink effect really limited RFA in those bigger lesions. So the answer has to be ASBRT for tumors greater than 2 centimeters.
Exactly right. A is the best answer. Wall showed 97% FFLP for SBRT versus 84% for RFA in tumors 2 centimeters or larger. For smaller tumors, no significant difference. That's a key takeaway.
Definitely a board favorite, that distinction.
Okay, case 2. Per K1 Tech guidelines, what is the mean liver dose constraint for 3-fraction SBRT for primary liver cancer aiming to keep the risk of classic radiation-induced liver disease below 5%? A, 13 gray. B, 16 gray. C, 19 gray. D, 21 gray.
All right, K1 Tech, mean liver dose, 3 fractions, primary HCC, likely cirrhotic liver. That brings us back to that critical threshold for minimizing classic RILD. The number that sticks out is 13 gray, so I'm going with A, 13 gray.
You got it. A is correct. The K1 Tech summary is very specific. For primary HCC and a cirrhotic liver, the recommended mean dose constraint for a 3-fraction SBRT regimen is less than 13 gray to keep that classic RILD risk below 5%. Options B, C, and D are too high for this scenario.
A number you just have to know for safe practice.
Absolutely. Final one, case 3. You're evaluating an SBRT plan for a large HCC. Prescription is 45 gray and 5 fractions. Total liver volume is 1,800 cc. GTV is 300 cc, meaning the uninvolved liver volume is 1,500 cc. The plan shows that 900 cc of the uninvolved liver receives 14 gray. What's the most appropriate action? A. Approve the plan as the mean liver dose is likely low. B. Approve the plan as the V20 is likely acceptable. C. Reject the plan as the critical liver sparing constraint is violated. D. Reject the plan as the GTV is too large for SBRT.
Okay, let's break this down. The critical liver sparing constraint, that's the V less than 15 gray, needs to be greater than or equal to 700 cc. We have 1,500 cc's of uninvolved liver. The plan says 900 cc receives 14 gray. 14 gray is less than 15 gray. So does that mean 900 cc meets the criteria? Wait, no. The constraint is about the volume receiving, less than 15 gray. If 900 cc gets 14 grays, that means only the remaining volume, 1,500 minus 900, which is 600 cc, receives less than 14 grays.
And therefore also less than 15 gray.
Right, so only 600 cc receives less than 15 grays. And the requirement is 700 cc.
So
the plan violates the constraint. 600 is less than 700. You have to reject it. The answer must be C. Reject the plan as the critical liver-sparing constraint is violated.
perfect breakdown. C is absolutely correct. Even though 900 cc gets only 14 gray, that still leaves only 600 cc getting less than that dose. It fails the V15GY 700 cc rule. Approving this would be a major safety error. Options A and B might be true, but they don't matter if the critical constraint is violated. Option D, GTV size, might be large, but isn't necessarily an absolute contraindication if constraints are met. C is the definitive reason to reject.
It's a common pitfall, focusing on what a volume receives versus ensuring enough volume receives less than the threshold. You have to read those constraints carefully.
Excellent. Okay, let's quickly summarize the key learnings from this SBRT masterclass. First, big point.
SBRT offers superior local control compared to TACE and RFA for many HCC patients, especially those with larger tumors where things like the heat sink effect limit other methods.
And second,
It has a proven incredibly important role in high-risk disease, particularly for patients with portal vein thrombosis, PVT, as RTOG 1112 showed us. It's a real breakthrough for those challenging cases.
and the keys to safe delivery. The non-negotiables.
Two absolutely critical dosimetric principles.
Yeah.
First, respect that uninvolved liver constraint. V less than 15 gray must be greater than or equal to 700 cc, prevent RILD.
It's safe.
Critically, avoid high doses to that central biliary no-fly zone. Keep the V40 below 21 cc for 5 fractions. Prevent devastating biliary stricture.
Those principles are paramount. Patient safety, treatment efficacy. They let us confidently offer SBRT as a curative intent local therapy for HCC.
So as you go forward in training and practice, keep those constraints front and center. That's the difference between just a plan that looks good on paper and a truly great outcome for your patient.
Well said. This wraps up our comprehensive look into primary HCC and the real power of SBRT. It's evolving fast, so staying current is absolutely key.
Absolutely. And next time, we'll finish our liver series with part 3. We'll be focusing on biliary cancers and metastasis management.
Another area where Red Onc plays a vital, evolving role. Looking forward to it.
Me too. Some exciting developments there as well.
For show notes and complete practice oral boards, you can visit radoncSmartLearn.com.
And please be sure to subscribe to Red Onc Smart Review wherever you get your podcasts so you don't miss our next session. Thanks for tuning in.